on Social Samhita Adhyayana. Without further delay, I would like to call upon Dr. Muralidhar Sharma sir, STMC AOP, to take over the session. Welcome to you, sir.
Now, we had started from this Vishikhanupravesh Adhyaya, and we had stopped somewhere in between. Let us continue from the point where we had stopped there. Now, in the previous session, we had discussed about the method of or the conditions which are required for the practice, or that the conditions in terms of the quality norms which a physician has to follow. Now, the next part is about the clinical examination, how to deal with the patient. To deal with the patient, the pattern of medical practice in those days in Charaka or Sushruta was something different from what we see now. In those days, if a physician would go to the patient's home and then examine the patient there and then treat. So it's the medical services going to this patient, not the other way. Patient coming to the medical services or hospital center type of service was not available in the, or rather not the practice in those days, whereas in the present day situation it's the other way. The patient coming to the physician and is a physician centered services now. Advantages and disadvantages of these two systems, of course, is a different issue. Of course, from having the physician centered practice, you can save resources, you can deal with more patients, and so on. These are the advantages. Whereas if it is a patient centered one, the quality of service would be better. In the current situation, too, in many of the Western countries, there is a discussion about changing this model or having a hybrid model where a model of patient centered as well as a physician centered practice may be introduced, and so on. That's one of the high level issue of the controversy. I'll not waste much time on that part, but that's another interesting development in the new contemporary medicine, like having an alternate method of a patient-centered system, and then advantage of that patient-centered system is being now discussed, and maybe in due course of time in future we may have a sort of different model, a hybrid model as such. Anyway, that's one part. Now, when it is the other way, when a physician has to move to the patient's party, the concern of the physician about the patient would be starting the moment the physician knows that the patient is ill, there is a patient is ill, and hence the attempts to diagnose, attempts to manage that patient starts from the moment he gets a message, and hence ततः दूत निमित्त शकुन मंगल अनुरोम्येन आतुरगृहम अभिगम्य. The physician has to go to the aturagriha, the house of the patient, and during that movement he will be considering about the possibilities or prediction about the prognosis, possibilities about the diagnosis, and possibilities of the options of the treatment. All these are to be studied or are to be concerned by the physician, and because of that concern, even the this messenger also would be one of those saints. Now, in the later chapters, in the later chapters of 29th chapter, where we will have Indriya Viparita Adhyaya, there we will have more discussion about this Duta Darshana, etc. Now, what the basic idea of that Duta, the messenger, and the personality of the messenger, behavior of the messenger, giving you an idea about the possible outcome of the disease, is suggestive of the concern of a physician about the patient. Now, in the later chapter, we will have more discussion about this later as such. The description is Duta Darshana Sambhasha Veshaha Chestidamevata Riksham Vela Titishiva Nimittam Shakuno Anidaha. Now, the personality of the messenger and his behavior, the anxiety of the messenger, all these would be a mirror of the condition of the patient. If the patient is in a critical condition, the messenger would have certain sort of anxiety, or his behavior would be somewhat odd. And considering that, the physician would have some idea about the severity of the disease. That's the real practical base of that Dutani Shakuna as such, the predicting the prognosis based upon what the messenger says. It's not something an occult practice as such, and it's practically true also. Then there is another is the nimitta. Nimitta, the description of nimitta in Charaka Samhita is very in rather more detail as such. In Charaka Samhita, the possibility of prediction of the prognosis based upon two basic factors. तत्र खलु येषां परीक्षाणां कानिचित् पुरुषम् अनाश्रितानि कानिचित् पुरुषे संशयानि. Certain of those factors which can be used for prediction of the prognosis are considered outside the body of the patient. It's not within the body. And certain of those are the Purusha Samshayani. So that Purusha Samshayani, those which are seen in the patient, they have to be examined by Prakrititaha and Vikritascha. Purusha Samshayani Punaha Prakrito Vikritascha. Purusha Manashitani, those factors which are not really based on the person of the patient, they have to be perceived based upon your previous knowledge, upadesha, yuktidashta, the skill, the experience. That's what we call as the sixth sense. Once you get into the practice, you'll come across this issue, and it's absolutely true. Like, though otherwise, from the rational point of view, there are some incidences which are not directly related to the disease, but still the prognosis of a disease can be predicted due to certain extraneous issues, and those extraneous issues are the nimitta. Nimitta is nimittanurupa, nimitta arthanukarani, तान् अनिमित्तां निमित्तम् आयुषक्तयं प्रमाणज्ञानस्य इच्छन्ति विषयः भूयश्च आयुषक्षय निमित्तां प्रेतलिङ्गानुरूपां याम् आयुष अन्तर्गतस्य ज्ञानार्थम् उपदिशन्ति धीराः. So those factors which are not directly related to the patient's body, which are not directly physically related to, also can be considered as a factor by which you can create the prognosis. So this issue is a controversial issue, like whether that extraneous factors would be predicting the prognosis or not is a controversial issue. The objective medicine, evidence-based medicine may not accept this, but with the clinical experience, I can assure that this is true. You can have that kind of feeling when you go into the practice, and as you mature in the practice, you will come across many of those factors as such. And that's again very interesting topic which can be discussed separately, but we'll just stop at that level. Then once the physician goes to the patient's home, he has to sit comfortably, upavishya, आत्मन् अभिपश्येत् स्पृशेत् पृच्छेत् च त्रिभिः एतैः विज्ञानोपायैः रोगाः प्रायशो विदितव्याः इत्येके तत्तु न सम्यक् षड्विधो हि रोगाणां विज्ञानोपायः तद्यथा पञ्चभिः श्रोत्रादिभिः प्रश्नेन चेति. Now once you go to the patient's home, sit comfortably and have a rapport to develop with the patient, and then start with the examination. And the examination would be darshana, sparshana, prashna. That's one way. Like you'll have to inquire about the condition, then palpate the body so that you can have feel those changes which could be seen, as well as the darshana, examine visibly any visible signs of the disease or visible signs of the possible prognosis they have made out. Now, there is a issue of a difference of opinion. It's not only the Trividha Pariksha, it could be Shadvidha. That means you have to make use of all the sensory organs, including all the sound, the Shabda, Sparsha, Rupa, Rasa, Gandha, all these sensory perceptions should be used as such. This is one way of what Sushruta says. Of course, this is absolutely true. To find the evidences of the disease, you will have to make use of all the resources. And when you say, like making use of the Shrotrendriya, the perception of the sound, Shrotrendriya Vijnaya, Visheshaha Rogeshu, Vranasra Vijnane Vishu Kshante, Tata Sapenam Raktam Irayan Nilaha, Sashabdo Nirgachati Ityavamadeha, feeling the sound of flow of the blood. Now, feeling the sound of the flow of the blood, now you may have a stethoscope, you may have a Doppler instrument, beyond what simply the capacity of the ear is there. So you enhance the capacity of that auditory sense by making use of either a stethoscope or a Doppler, but still that comes under the Stotrendriya Vijnaya Pariksha. और स्पर्शनेन्द्रिय विज्ञेयः शीतोष्ण कर्कश मृदु कठिनत्वादयः स्पर्श विशेषाः ज्वरशोपादिषु as such. So feeling that variation in the temperature, feeling the variation in the consistency or the quality of the surface like soft or hard. So these are the palpatory findings which are mentioned by Sushruta. Now of course we may have more sophisticated tools like the ultrasonography or even the sensory these thermographs, thermocouples, etc. to make out these issues, or thermometer to assess the fever, more objective, but the feeling would be, the signs would be the same. चक्षुरिन्द्रिय विज्ञेयः शरीर उपचय अपचय आयु लक्षण बल वर्ण विकारादयः which can be made out with the chakshu, the visible. It's about the build of the body, the nourishment of the person, the physical activity, the physical status of the patient. These can be assessed by the chakshurindriya visible. Now, of course, you can enhance the scope of your chakshurindriya either by making use of the microscopes where you can go into the micro, or making use of radiological instruments where the range of the visibility can be enhanced. So you have multiple choices, and maybe the scope of the Chakshurindriya Pariksha may be enhanced as such. रसनेन्द्रिय विज्ञेयः प्रमेहादिषु रसविशेषाः घ्राणेन्द्रिय विज्ञेयः अरिष्टलिङ्गादिषु व्रणानां रौणानां च गन्धविशेषाः रसनेन्द्रिय विज्ञेय and घ्राणेन्द्रिय विज्ञेय परीक्षा are where you may either appreciate the taste or the smell produced due to the disease. Now, in the present day situation, you may not directly appreciate the taste by making use of your tongue or the nose, but you may make use of all the biochemical tests. All the biochemical tests which you see in the laboratory, they are a alternative to either the Rasanendriya or the Grahanendriya Pariksha. The basis is when you say that you have tasted something, it means there has been a chemical reaction in the tongue, and because of that chemical reaction, you appreciate the taste. So instead of appreciating that chemical reaction within your body, you prepare that, get that chemical reaction outside in the laboratory into a test tube or some other instrument, and derive the conclusion based upon that. And hence, all the biochemical tests which we do can be considered as a replacement or a new development of making use of that, instead of simply making use of your sensory organs as such. प्रश्नेन च विजानीयात् देशं कालं जातिं साप्यम् आतङ्कसमुत्पत्तिं वेदनासमुच्छ्रायं बलम् अन्तरग्निं वातमूत्रपुरीषां प्रवृत्तिम् अप्रवृत्तिं कालप्रकर्षादींश्च विशेषान्. A history, getting the detailed history. Now, when you say in the contemporary method of taking history, it's exactly the same protocol where you take the history about the onset of the disease, the duration of the disease, and the factors which affect those disease, the then personal history, family history. Now, exactly the same is mentioned by Sushruta as a Desham, Kalam, Jatim, Satmyam, Atankam. These are exactly the different variations of the different varieties of the history. So, as such, when it comes to the question of examination of the patient, there is no basic difference in the approach. The difference comes in only the use of the technology now. Now we have more technology, and the scope of the examination is now more, whereas Sushruta's time, those technologies were not available, but within those available technologies, Sushruta had used all those tools to make out the possible diagnosis. Now, once you have identified those abnormal, these examine the patient, another basic question is when to consider a sign as normal or abnormal. That's the issue of interest. You may feel that one person has maybe feeling the body is hot, but whether it has to be considered as a really produce the disease fever or not. Now, in that condition, the idea of Sushruta or the tradition of Ayurveda says Atmasadrisheshu Vijnana Abhipayeshu Tat Saniyehi Vijnaniyat. There has to be a comparison of the same feature in the person who examines and in the person who is examined. So if these show a difference, then it's considered to be disease. Now this is a very interesting issue. Uh, Now, when question of temperature, now if it is a question of body temperature, The body temperature may vary significantly according to the environmental condition. In hot weather, if you are having a hot weather and a cool breeze moving around, your body temperature may be slightly higher. If there is more sweating, the temperature may be slightly lesser. If you are sitting in an air conditioned room, then the temperature will be much lesser. So there will be some variations due to those extraneous factors. Now, if you go on by the standard parameters of what we call as the statistics, in the present day situation, the normal or abnormal, call it these factors, when to consider as a normal or abnormal, is based upon purely statistics. Statistics is the fundamental factor of the modern medicine, and the growth of the modern medicine is dependent upon the statistics very significantly. Now, in the present day situation, you decide about that normality or abnormality based upon what we call as the distribution curve. So you collect the data of a large number of population and then plot it in over a graph paper, and the graph would always show a curve. It's not that there will be a straight line, because every human being is never equal. There is always a individual variation, and that individual variation could be produced due to multiple factors. It could be internal factors, it could be external factors, and most of the times those external factors would produce a change significantly, like the environmental factors. To give an example, another example, the hemoglobin percentage. Hemoglobin percentage, according to your textbook, the normal is 14, above 14 grams. But if you see the hemoglobin percentage of the population of rural people, most who are living in the rural area, where there is a better oxygen concentration, the average would be much lesser. It's never 14, it would be something 12, 10 or so on. If you go to an urban city like Delhi, where there is a significant pollution, the average hemoglobin level could be still higher. Now, this average hemoglobin level is produced due to or changed due to a physiological reaction depending upon the concentration of the oxygen available in the environment. So in urban environment where there is a pollution and oxygen concentration available is lesser, naturally body has to have more hemoglobin, so hemoglobin concentration will be increased. Whereas in a rural area where there you have a better air, rather better quality air, you don't need that extra hemoglobin, so hemoglobin concentration will be lesser, obviously lesser. Now, if what happens is, the according to our medical jargon, the rural people have anemia, urban people are better. This is what jargon would say, and then you will have lots of budget spent on improving the quality of life of rural people, supplying iron supplements to the rural people, and so on. The whole fallacy is that. Now, this is because of this statistical average problem. The statistical average problem doesn't take into consideration those variations which could be produced. So when you have a graph of this sort, you will assess the median value and standard deviations. Statistics, I think it's a very interesting as well as very thrilling subject. If you assess that median value and then the standard deviations, you may include this range of these data within the normal range. But those who are beyond that scope of this range, they may be considered as abnormal, though they are normal, and hence there is a possibility of unnecessary interventions or unnecessary diagnosis and so on, and that's one of the major issue of concern now in the current medicine, like how to correct this. And the problem would be more when the curve is more flattened instead of a dumbbell curve. If it becomes a rather flatter curve, then you will have more people beyond this standard deviation, and most of the biochemical values which we use, and when you get the results in the laboratory, you will have a range mentioned about. Most of these values are meant for or mentioned for the western countries, in the western situations where the environmental factors, geographical factors are different, and the dietary factors are different, lifestyle factors are different. And very interestingly, in India, hardly we have any of those biochemical values which are analyzed, standardized for our living conditions, and hence unnecessarily there is a possibility of making a unnecessary diagnosis, over intervention, or so on so forth of that problems. So instead of going for that universal biochemical standards or standards based upon the statistics, if there is a model of comparing the population, the data of the local population or the same person who is examining the person, another individual to individual who is living in the similar environment, who is having a similar lifestyle, the chances of having such an error would be lesser. So, a new idea in the assessment of these biochemical values would be of having a universal biometric situations and biometric situations based upon this environment factors. This is one of the advanced thinking in the contemporary medicine. Even still, there are no standard practices coming out. Statistics, after all, is a very interesting as well as a dangerous subject. I have put in a cartoon here. Like statistics says that the average depth of the river is 3 feet, but that doesn't mention about a possibility of a deep hole or a swirl in between. And if you depend upon the statistics alone, there is a possibility that you may go into the accident. So to prevent that, this is a real concern in the contemporary system also. And when I say this, I am not denying the value of statistics, definitely yes, but there is a flaw in the statistics and that flaw needs to be corrected. And only one option of correcting this flaw of the statistics would be going back to a model where a smaller data is compared to a specific target data, and this kind of a model is not yet fully developed anywhere. Of course, with the method which is mentioned by Sushruta also, there could be one error. Suppose the doctor itself, the physician himself, is having a disease, he himself has a fever, then if you compare the temperature to the other person, you may miss that. So these kinds of errors are possible. So some conditionalities have to be there, and maybe in future you may have a different model based upon the best of what the tradition has said and what the current statistics would say. Now that's one of the very interesting issue, and from Sruksha's point of view, we should go on highlighting this part, like a comparison of a abnormal feature, physical feature, to a person of the similar age group, similar environmental conditions, and that external factors being constant, and hence depend comparing that factors of the body, physiological parameters, and concluding that that kind of a concept is a concept of the future. And hence we need to highlight that part has to be highlighted as a speciality of Ayurveda as such. Now that's one part. Now next, once you have made out this, listed the possible signs and symptoms, and possibly you have made a diagnosis, then the next part is predicting about the prognosis. That prediction of the prognosis is another complex job, which is based upon your clinical experience and the other factors related to the life as such. And that prediction of the prognosis we'll deal with more in detail when we discuss with the Arista Lakshanas in the consequent chapters. Now, once you have made that prognosis, evam abhisamiksha sadhyan sadhayet yapyan yapayet asadhyan naiva upaprameta parisamutsarotisanscha vikaran prayasho varjayet. Now, once you have made the prognosis, to make the best use of your skill and the experience, you have to ensure that all that whatever the effort you do would be fruitful. You will be preferred to treat the patients who are having a better prognosis. Those patients who have an extremely poor prognosis, it's better not to treat them if you have the other option, the treating the better option. Now, this kind of an approach is again very, a very advanced development of the modern science also. In the modern science, you have that method of categorizing the patients, and if you have a patient with a poor prognosis, and if you make use of all the resources for the sake of that patient of poor prognosis, where you cannot really have a better outcome, then and that resource cannot be made use of to a person who has otherwise a better prognosis, that will be a rather injustice. And hence, whenever there is a crunch of resources, as in case of a mass casualty like conditions, you will have to first categorize the patient, and then only those patients who have a better prognosis, better chance, they have to be treated first. And then once you have they treated that category, then if you still have the resources in terms of medicines, instruments, and the person and so on, beds and so on, then the next category has to be treated. And this kind of an approach or selective taking of the patient, selective acceptance of the patients is another advanced technique of the contemporary science, preference of the patients. And this is exactly what Sushla has said. एवं भिक्षा साध्यान् साधयेत याप्यान् यापयेत असाध्यान् नैव उपक्रमेत परिसमुत्सरोचितांश्च विकारान् प्रायशो वर्जयेत. Very chronic diseases where you may not have a better chance, it can be treated. This can be avoided. Now, this doesn't mean that you have to reject the patient. It's not a question of rejection of the patient. It's about making the best use of the resources. Suppose you have no other patients, it's only that asadhya patients have come in, yes, definitely you have to treat them. You have to prefer to treat them. So that's the point which you have to make out. Now, मिथ्यादृष्टाः विकाराः दुराख्याताः तथैव च तथा दुष्परिदृष्टाश्च मोहेयुः चिकित्सिकम्. So, a possible confusion in the practice can occur due to a wrong perception of the science, mithyadrashtaha, or durakhyataha. If the history is not given properly, if the condition is not explained properly, then also there could be a error of the diagnosis. Tata dushparimistashta, a wrong conclusion. Suppose you have seen a sign, you have got the history, but this has to be interpreted, and if this interpretation is not proper, then too there could be a wrong diagnosis. So, hence, to have a perfect clinical approach, you have to have a thorough clinical history taking, thorough clinical examination, and your background knowledge. The previous experience as well as the theoretical knowledge is very crucial, and these three are the major factors which make the diagnosis as such. तत्र साध्याः विवादयः प्रायेण येषां दृष्टिचिकित्समाः भवन्ति तद्यथा श्रोत्रिय नृपति स्त्री बाल वृद्ध भीरो राजसेवक कितव दुर्बल वैद्यविदग्ध वैद्यविदग्ध व्याधित गोपक दरिद्र कृपणानां क्रोधनानाम् अनात्मवतानाम् अनाथानां च एवं निरूप्य चिकित्सां कुर्वन् धर्मार्थकामेषां सिद्धिं प्राप्नोति. Prognosis of a condition is not made out only with the factors of the disease, your clinical diagnosis. The factors of the lifestyle also can change the prognosis. Those lifestyles where the patient cannot give attention to his food, his activities, and so on, and are those who do not have a resources, then there too cannot be treated proper. The prognosis can change. So Sushruta says, Shrotriya, those Purohits who are dependent on the food of multiple sources, kings, again, because they eat more, overeat, and they do lesser exercise, stree, women as such, because of their lifestyle, and of course, dangerous to say about now in the present day situation. Bala Vruddha, younger age or very old age, and those who are government servants, Rajasevakaha, and Vaidya Vidagdha Vyadita, a person who has very chronic disease, and hence he himself would be better than a doctor many times, or commenting on the medicines and doctors. Those are the ones where the prognosis can be changed due to the either due to the variant lifestyle, or due to a abnormal or a irregular or rather a wrong perception about the disease and the management, or those who do not follow the instructions properly, or then those who do not have the resources like anatmatanam manathanam. That doesn't mean that they have to be rejected. They need to be treated properly, but you should be able to predict the prognosis based upon that. Now, all this is what we call as a medical consultation. When we say a medical consultation now, it involves all these steps: a correct assessment of the disease and correct prediction of the prognosis. Now, from the present contemporary point of view, the skills of medical consultation is another major issue more than the theory subject. See, in the medical studies, one major portion of the study is your study of the anatomy, physiology, pathology, and so on. So that's that part, that theory part. But another major part which is often neglected, but if there is a huge thing to be studied, is the techniques of medical consultation. And after all, the medical consultation as such is rather some of patient's needs and expectation and doctor's knowledge and experience. So if when there is a some area of merging of these two, patient's expectations and doctor's experience, then that consultation will be successful. If there is a gap, the gap becomes wider and there is lesser overlapping area, then the consultation will be unsuccessful. And it's possible to have a successful consultation. You need to have two aspects: one, the clinical skills and the communication skills. Clinical skills is based upon the theory knowledge. Communication skills is another very complex issue where you gain the confidence of the patient. To achieve that, in the contemporary system, there are many consultation models. Those many consultation, again, I will not go into all the details, very frequently used, and that's a very big subject. Consultation and consultation models and their utility, advantages, disadvantages is a very huge subject, so I will not go into that, but I have just listed a few of those very popularly used different consultation models. And from my point of view, consultation models of my preference would be the Fraser model, which is exactly almost a similar copy of what Sushruta has said. And in that consultation model, the sequence of the events in that consultation model will be: you have to interview the patient, take the history, then the physical exam, then the patient management where you go for the investigations, and then of course the record keeping is the last part. This also is quite critical, and this portion, this method is one of the most useful, and it resembles most of that major portion of what Sushruta has mentioned about, where the investigations and the diagnosis made by the patient. Many times you will have the patients of Google experts who make the diagnosis and then come to you, or those who have bundles of investigation reports and then come to you. See, you might have observed that in the clinical OPD, I never look at those investigations before I make a diagnosis. So, examination of the patient on your own, and then coming to a possible diagnosis, then going into that next exclusion diagnosis based upon the investigations and the previous reports. That would be a better model, and that's a Fraser model, and that's what I prefer. Of course, in the current trend, the most popular current trend is a Calgary Cambridge method, where the method is simply gathering of the information, and more is about the building of the personal relationship, and it's about the explanation and planning rather than having a active involvement with the diagnosis. I will not go into that part. Now, those who are interested in this issue, like having different models of this consultation and their utility, I will recommend you to read this book, The Doctor, His Patient and Illness, written by Michael Barrett, who is a psychoanalyst. And very interesting, and the most concluding part of that book is it's not the drug which makes the difference, but doctor is the drug. Now, the consultation skills, communication skills in the patient, they come to that level where the patient would have some confidence on the doctor, and most of the times the medicines, more than the medicines, a touch of a doctor or a few words of the doctor can help the patient to recover a lot, and this skill is another major area. Of course, the part of the theory and theory study is absolutely vital. Without that, you cannot reach that level. But once you have reached that level of having a able method of clinical diagnosis, the next part, the clinical skill, the communication skill, and developing the confidence of the patient is a very crucial issue. And you might have seen many of the times the patient saying that the moment you look at the doctor or the moment he talks to the doctor, she feels better. These things are absolutely true, and it's not simply a placebo, it's not simply a useless thing, it's a useful thing, and it can be developed in the clinical practice and can be used too for the welfare of the patients. And so that is a very vast subject, so I will not waste more time on that. But those who are interested, they may read this book, which is a very elaborate book on these aspects, deals with these aspects in detail, and quite interesting. Now, the next part is about your behavior during the clinical practice. Sushruta says, Stribi saha asyam samvasam parihasam chavartayet dattan chatabhyam nadeyo annad anyat bhishagvarehi. Sushruta advises the physician to maintain a visible character. And the word used by Sushruta is you are not supposed to mingle with the ladies, Stribihi, Sah Asyam, should not sit with them, Samasam, should not live with them, or should not laugh unnecessarily with them, and should not take anything, receive anything other than eatables whenever there is a need. Now, it's not that Sushruta was a feminist or Maoist, rather anti-feminist or Maoist. It's not that way. In those days, probably a majority of the physicians were males. Number of female physicians were lesser. Of course, history of contemporary science also is like the first doctor, female doctor, she came in only in 19th century. So that's the part. We'll not go into that part. But there is another, is in the present day situation when you translate Sushruta, you may, I change this word from Stribihi to the opposite sex. When you deal with the person of opposite sex, you have to be presenting yourself where there is an absolute perfect character. There should not be any suspicion of the character. In the current medical world, one of the major area of concern is sexual misconduct complaints against the doctors, and these are jumping throughout the world. It's not only in India. Of course, compared to other countries, the incidence of that medical this misconduct, sexual misconduct by medical persons seems to be statistically lesser in the years to come. These are all from the different sources. Source is United Nations Office for Drug and Center. And this graph, India is comparatively seen at a lower level compared to other countries, the Western countries. In California, these incidents of medical these complaints are increasing rapidly. Now, when we say that the India is that blue line representing India is in a lower level, it doesn't mean that really it's in a lower level, because the chances of reporting those issues in India are lesser. So these are depending upon the reported cases. Anyway, now it's one of the major concern and major subjects dealt with many platforms. The misbehavior of the physicians with the persons of the opposite sex and character, the integrity of the characters of the medical profession is one of the hotly debated issue, and hence there is a need to have a separate concern about this fact, because a physician has a larger opportunity to deal with the persons of the opposite sex, and there is a possibility of more physical interactions, and these physical interactions should not go to the level of misunderstanding, and that is the concern when Sushruta says about this statement. So having a visible perfect character, and doctor's personality is always assessed by the society in different angles, and to present that personality in a proper manner is also an important issue of the successful career. With this, we will conclude the Vishikhanupravesh Adhyaya. Iti Sushruta Samhitayam Sutrasthane Vishikha Anupraveshaniyo Nama Dashamoadhyaya. Summary: transition of a medical student to a professional is a very significant event. Guidelines of practice mentioned in Samhita are very relevant today also, and regulation of medical practice in ancient India was very objective compared to what Hammurabi had said. Every practitioner should know about the existing regulations about the profession. Care of the patient is the ultimate aim of the career. With this, we'll conclude today, and it's only 5 minutes left, so we'll conclude today. And if there are any questions, we'll interact. Otherwise, we'll conclude today. Fine. No questions? Fine. Okay. We'll start with the new chapter in the next session. Right?
Thank you, sir.